My name is Dr. Regis. I'm standing in for Dalit. I'm IVF specialist and a geneticist, and I practice mostly in prenatal and pre-gestational diagnosis. I don't myself diagnose autism. And I'm here to talk about the possibility of maybe preventing autism. So as I said, I'm an IVF specialist and a geneticist, and I practice in the field of prenatal screening and pre-gestational diagnosis, which means IVF babies and can we prevent diseases. And we'll try to talk about autism. I'm a bit late, and I'll skip some of the slides. Okay, sorry, technically challenged. No? Yay. Okay, the computer is slightly slow. We talked about autistic spectrum disorder, and I'll skip about, for the sake of time, I'll skip that. But we do see an epidemic of autism and a rising prevalence in this diagnosis. And previous speakers have talked about, is it because we're improving the diagnosis? Is it because the spectrum of the disease has been expanded? Is it because we're diagnosing girls more than we had in the past? This is all a possibility. We do know that we're talking about numbers much higher in the past. We used to talk about 1%, but perhaps this number is higher. And for me as a geneticist, it's important to know that it occurs in all ethnic backgrounds, which means it's not for some specific ethnicity, and that makes for a very, very wide and diverse possibility as far as the genetic diagnosis, as we've seen before. We still see a subset of children which are, and this is from the U.S., the slides are from the U.S., more white children, but probably a slightly higher diagnostic rates in higher socioeconomic groups. This is because maybe these are parents which are more aware or have a higher possibility of getting their children to diagnosis. And again, these are slides from the CDC saying that there isn't a decrease in the age of diagnosis, although people here have said things otherwise, and I think that's that's a very happy note. There is a decrease in the gender gap, and more girls are being diagnosed in the past. Is it because the prevalence is rising, or because we are identifying them better because they didn't fit the past stereotypical picture seen in boys? It could be an addition of both these two. And if I'm bringing it to where I stand, when couples come to me and ask me, well, can we prevent a second child? My take is, well, I need to understand why there is autism in the first place. We try to assess these risk factors, especially the genetic causes, and then maybe we can try to prevent a second child or perhaps a first child with autism. There was talk about the environmental factors, maybe the maternal immune activation theory about exposures during pregnancy. Is this the prematurity? Is this different factors that cause stress? Maybe obesity, as was described earlier, but probably these are risk factors that contribute when there is some sort of genetic predisposition, because not all obese women end up having children that are on the autistic spectrum. But if you have some sort of pre-inclination or have some sort of risk factor, you and your partner, then maybe this will go above a certain threshold, and then you will have this a child who is on the autistic spectrum. There's a lot of talk about the father's age. This is from, sorry, it's in Hebrew, but this is from Medical Ynet, which is an Israeli, I wouldn't call it paper, but it's an online news agency, which every now and then we get in the news that if a father's age is independent factor, maternal age is as well. I was on the way, I took the train here, and I talked to one of our IVF specialists who was very, very excited that I was going to give this talk, and he said that there is maybe we're up on the onset of a new epidemic because some of the things we do is we do egg donations. This is for women who can't have children with their own biological eggs. A lot of them are older women. And sometimes this would be a couple who may be 45 or 46 or 47 or even older. They'd get pregnant with an egg that's from a 25 or 26-year-old, but the father biologically would be 50 or sometimes 60. And I'm wondering, this is something that's been added recently in the last couple of years because this egg donation or ovum donation wasn't as popular in the past. And I wonder, I don't have the answer, this is a conversation I had on the way, if maybe we'll see a rise in these couples in autism. This is something would be interesting to look for in the future. So is there a genetic cause? Well, we know that in identical twins, vs. fraternal twins, there is a much higher concordance with autistic behavior and autistic disorders. So it would make sense. And we know that children, to a family that there already is one existing child with autism, the second child will have a much higher, is in a much higher risk for autism. So this already gives us a hint that there is a genetic cause, as we've seen in the previous talks. The recurrence rate, again, depending on which paper you read and what's the population of the people being tested, can be up to 18%, but it's much higher if it's not just autism, but it's autism with some sort of another background or a much complex, more disease. It's higher for males than females, either 3 to 4%, again, depending on which paper you're reading. And what's interesting is it doesn't really matter what functioning level is the older sibling, because the next one, it could be milder, it could be higher, but the next sibling will still be at risk, and this makes it much higher for us to give these genetic consultations, because the parents say, well, I know what this child is like, and I can deal with this much. But I've been to the clinic and I've seen so and so many children, and I can deal with my child. But if the next child will be much worse, as I've seen, I can't take that. So can you promise me that my next child will be just like the one I have, and it will not be worse? And unfortunately, these are things that we can't promise. Some of the recurrence risk, I think, is underestimated, because a lot of families that do have a child that is on the autistic spectrum don't have a second child. And then we don't know the real numbers because they just don't have the other child. We talked about the genetic basis, and there have been several talks. I'm going to skip a little bit about the genome projects, but many genes have been linked to autism in recent studies. And I think it's interesting to try and understand, again, this has been mentioned in the past, but I want to try to simplify it about what we do know and what we don't know, because it's easiest to find the de novo ones, the ones that are at highest risk, that there is for sure chance that the person carrying it will have autism or something on the spectrum. Some of these genes have been mentioned in the past. These are the ones that we can pick and choose. As far as I'm concerned about the recurrence risk and can I prevent, these are not the ones that I really count in, because if it happened de novo, it happened in the sperm, but none of the parents are carriers, then the risk is really small, and these are not on my list for prevention. Some of these couples do choose to get pregnant and then have maybe a testing during the pregnancy by amniocentesis, but they don't go for the whole full package of IVF and testing the fetus before we return it to the uterus, because the recurrence risk is small. We say maybe you're carrying it in your sperm or perhaps in your egg, so we can test for it, but if the recurrence risk is maybe 1%, you shouldn't go all out for IVF, which I'll explain what all out is. So if it's a very high risk factor, then you only take you only need that one factor for having an autistic spectrum child. If it's a not as high but rather powerful factor, then you need 2 copies. And again, the parents will be carriers, and the child, having inherited 2 such factors, then will have this disease or this something on the spectrum. Again, I'm not saying how bad it will be or what the exact phenotype is, but it's enough that you need to have 2. These we can also find. They're a bit harder to find. They're a little bit trickier, but they can be discovered. I'll discuss it in a minute. The problem starts when we get to the polygenic, the multifactorial types of things, where one of the parents is a carrier of a high load but very low risk variant, and the other one either has a moderate risk factor or both parents are carrying a higher load of low risk variants, but the child gets all of these things. And these are much higher, these are much harder to try to understand and to elucidate and then to diagnose. And again, if I don't know the reason, I can't help prevent it. And probably the common variants contribute a lot to autistic spectrum disorder. This is why we haven't been able to diagnose all or most of the children with autistic spectrum disorder, and they are hard to discover. The higher risk ones are the ones that are the ones that we find easier, and then maybe these are the ones that we can help prevent. But as long as we don't understand, prevention is much harder. This is another way of looking at it. This is from a paper that's been talked about. Again, it could be that the parents carry each some sort of load of common variants, but the child gets a very, very big load. They can be, one parent can carry these loads and another some sort of copy variant or something that is puts them at risk, or it could be something de novo, which is easy to find, but these are the rare ones. This is why we're talking about 1% or 1.5% of all the autistic spectrum genes. So what do we do if we have a child that is on the spectrum and we're trying to get some sort of genetic background? It's easiest for the most affected children, the ones that have maybe a congenital malformation, maybe they have some dysmorphic features, maybe they have another family member that is affected in a different way, maybe some sort of psychiatric disorder, as was mentioned here before. These are the ones where we will do a chromosomal microarray. We'll try to find a copy number variation, and these may pick up maybe up to 10%. Again, the highest chance for this is the more severe the condition. A lot of them are recurrent copy number variations, and the problem is with penetrance, which means that not everybody who is a carrier of this specific copy number will actually have an autistic spectrum disorder or any of the other phenotypes. I see this problem in a different field because I do prenatal counseling. And today in Israel, any woman who does amniocentesis will automatically get CMA, and we will know copy numbers. And then we get some of these copy numbers, and some of the time the parents are carriers, and they ask me, okay, so this is autistic genetic risk, so what are the chances that the child will have autism? I'm okay, I'm fine. I work as a bank teller, maybe some of them have more mathematical inclinations and are less social sometimes. It's nothing. And if the penetrance is not 100% or not 80% or not 50%, but maybe it's 20%, so what do? I don't know the answer to that, but these are very, very difficult questions. X-linked, Fragile X has been talked about. Okay, Fragile X is not just for males. Females can have Fragile X syndrome. They can be on the autistic spectrum disorder, so we test all children who are on the spectrum for Fragile X. This is paid for by the health ministry and is part of the health basket. And everybody else basically gets a whole exome. Paid for, not paid for, funded or not funded. That's that's a different debate. And again, you can get up to 20% diagnostic yield, again, depending on how bad the situation is. And many of these genes have been discussed in the past. This is a study that's been talked about the 102 genes discovered. I'm skipping ahead. It was a very wonderful paper. I want to talk a little bit about the male issue. As I said before, this is something that we've been dealing with. We know that the parental age has gone up. This is true for women, but this is also true for men. And a lot of the de novo mutations do originate in the paternal germline. There are many papers talking about that. And we know that the paternal contribution to the de novo mutation is higher than maternal. There is a maternal contribution. Again, the recurrence rate here is low as far as prevention, but if we know that this rate goes higher, and a couple that is beyond the woman's biological egg-producing time decides to opt for a baby and they go for egg donation, maybe as IVF specialists, we should talk to them about possible sperm donation from a young sperm donor. Because if they're at higher risk for autism, maybe this is something that should be discussed. It's not currently being talked about. Again, this is an ethical, slight medical issue, which I'm bringing up here. I don't know the answer to all the questions I'm bringing up, but it's an interesting, I think, something to talk about. So there are many modifiers. It's not a single gene disorder, and this makes my life as an IVF specialist harder. I have 4 minutes on my tape. There's a timer here. So what are the options for couples? They decide not to have children or to just take a chance and hope for the best. Maybe they can go for prenatal diagnosis, but then they have to just take a very hard decision of terminating a pregnancy, or they can try and do PGD or diagnosing the fetus before we actually put it back in the womb. This details going through IVF, which means the woman needs to have ovulation induction. She needs to have hormones being given to her, injecting herself for about 2 weeks. We need to do a surgical pickup of these eggs under anesthesia. We take the egg, we do intoplasmic sperm injection, we inject the sperm inside, we wait for, hopefully the egg will fertilize and will divide into 2 cells and divide into 8-cell embryo, and then we make a teeny hole in the membrane and take out one of these cells. This is from our lab. We can do it also on day 5 and take a couple of cells out. This is a wonderful film which I'm skipping, but with all our embryos sit in a very nice embryoscope, and we take little pictures of them, and we have a little film about each one of them. And then we can do an analysis, a PCR-based analysis. Again, this is when we know what the genetic cause is. If I don't know what the genetic cause is, I can't do any of these things. And hopefully we can transfer these babies and hope there is a pregnancy. In our medical center, we had 112 couples which had a diagnosis of either a child with ASD or they were carriers of conditions that are associated with ASD. They all underwent genetic consultation in our institution, and having understood the risk, they opted to do prenatal genetic diagnosis. A lot of them are Fragile X carriers. There is a screening program in Israel which screens all women, hopefully before pregnancy, for Fragile X. A lot of them were, 7 of them were carriers for tuberous sclerosis. 1 was a carrier of NLGN3, and 11 were carriers of copy number variants. You see here chromosome 15, 16, 22, which was mentioned. 7, no causative mutation was found, including WES, and they opted for sex selection, which I'll talk about in 2 seconds. We had 61 children delivered after Fragile X, 7 for tuberous sclerosis, 5 after we diagnosed a copy number variant, and 3 who opted for sex selection for female embryos. Some of the stories are very heart-wrenching. We had a woman who had 3 children diagnosed with Fragile X before she came to us, 2 before they was even diagnosed in Israel. The daughter was a misdiagnosis in amniocentesis, and you can understand that the woman was rather older. stage, but we managed to have a healthy boy with our treatments. The setup of PGD analysis is rather complicated. I won't go into that. What I would want to, another question which I don't have the answer for, is about sex selection for females. The Israeli Society for Fertility put up guidelines, thank you, sorry, I missed the word. This is in 2013, I think we need to update it, which basically states, sorry, this is in Hebrew, that this is possible if the doctor tells the woman exactly what are her risks, and if we don't find the cause, then we can think about doing PGD for sex selection, and if the prevalence is higher among boys, maybe this is a possibility. But then we look at the numbers exactly. 2 slides. I have 2 slides, please. We look at the numbers exactly, and we see that it depends who the older sibling was and what the next sibling sex is. Because if the older sibling was female, then apparently the mutation load or the genetic load is much higher, and the risk for a second sibling is higher, no matter its sex. If the first sibling was male, then the risk for the second sibling will be lower. The best case scenario is if we have an older sibling which is female, and then the second one will be male, which is maybe contrary to what people think. And I'm not sure what the answer for this. We used to do sex selection for females, but the numbers have changed. And I'm not sure this is the answer. I think the answer should be towards trying to elucidate the genetic reason, and then if we do have a recurrence risk, then to offer PGD, because PGD and the whole IVF treatment are not innocent by themselves. Thank you. 1 minute, everybody.